Hello, everyone. This is Dr. Cross, and I wanted to use this video to provide general feedback in terms of things that I saw, and also some helpful tips in thinking about writing, completing your part two for assignment one. Just FYI, before I get started, I just want to remind students that, when you think about your clients and writing them up, I really want you to think about all the things that you've learned up until this point in the course. What is abnormality? How do we know when something abnormal is going on with somebody? And we had a discussion board about it. I also want you all to think about ethics. And our second week, we covered ethics and mental health. And some of the key things I want you to think about in terms of ethical practice is one, competency of the worker. What are our social work code of ethics and our duty to clients and duty to society as social workers? And so for this particular assignment, I want you to think about when you're reviewing cases and understanding how to write a case conceptualization and case study, that we're always client centered and we're trying to do no harm. We're there to help and support clients, not add to their problems. And so from an ethical standpoint, diagnostics and diagnosing is important, is key. It's our way to help clients. And we have to practice in a competent way as well as a culturally competent way. And so for this, the work of the social worker here is to understand what's going on with the client, um, piece together the puzzle and support them. One of the things I would encourage you to think about is misdiagnosing, right? And so the key and the work, and I know that with this assignment, you all are starting to see how much work and how difficult it is to diagnose, because one, patients and or clients, they don't present in these wonderful categories. We wish they did of the DSM-5. They don't come in saying, hey, I have this disorder in criteria A, B, C, D, 1, 2, and 3 applies to me. That rarely happens. What we have to do is sit down with clients and understand and learn their history, learn their problems, and learn them thoroughly. And then now we have to start understanding or thinking about, okay, these are pieces of the puzzle. And the more of these pieces I can piece together, the picture will become more clear. But you need as many pieces of the puzzle, and you have to put as many of them together to understand what the picture is supposed to be. I think of a jigsaw puzzle. And so one of the things that I worry about when I'm reading case studies and reading it is, one, when clients have too many diagnoses, right? To me, that's not ethical practice. Clients shouldn't have 5 or 6 disorders. And if they do, and they're historic, meaning they were disorders that were given over time. But if they're presenting with 5 disorders, I wonder if we're serving clients ethically, or is misdiagnosis going on here. We owe it to our clients to put the work in and get it right. It's why I strongly encourage students to pick one. Right? It's harder to do, but instead of trying to label clients with a bunch of disorders, which follow them forever, mind you, we want to get it right. And you can't prescribe and treat for 5 different disorders. You need to find one, maybe 2, but I strongly encourage sticking to one, even to simplify your write up. It's very hard to do. And so really think about it. The other work in terms of competency of the social work is not duplicating a diagnosis because it's in a client chart, right? That's like copying somebody's test, right? You wouldn't do it. It's not ethically appropriate practice. It takes the worker out of the equation, and it takes your skill set out of the equation. What I prefer that you do is write the presenting problem using this case study guide, right? Using the chart, using the background information to help you fill out the case study, but then put the chart away and study your case study guide only. Really look at the puzzle, pieces of the puzzle. Connect the dots or put the puzzle together, and then paint me a picture of a diagnosis. And so hopefully that helps you understand what it is, you're supposed to be doing. If you found that this assignment was hard, good. That means you're growing. That means you're learning. You're understanding the complexity of the work of diagnosing. And you're understanding and hopefully appreciating the work involved in diagnosing. So from that standpoint, I'm going to move on and go through the case study guide. But again, I really want you all to hopefully understand the importance of picking one diagnosis for your client and making sure that diagnosis is the picture of the puzzle pieces that you put together from the case study guide. So this section right here is supposed to be completed fully. This section can be duplicated in your part 2 write-up. If you just wanted to copy and paste this section because it takes up very little space, that is perfect to do. I've seen students put this in charts to insert a chart with this information to try to reduce space, and that's fine as well. All this information needs to be listed here and as thorough as possible for your client. Presenting problems should be brief. This is a brief summary of why the client is seeing you. For some of the students, it was for housing. Some for students listed substance use problems. Here you can put not just what the presenting problem is, but also consequential problems. So you may say client is experiencing substance use, has been using drugs for 10 or 15 years or something like that. Be specific on the drugs, abusing alcohol is a summary. Don't go into details of the substance use because there's another section of the paper the more deep where you're going to provide the details of substance use history. But here, just say client struggling with substance addiction or addiction for many years, has lost their home, their job, their children are placed in foster care due to substance use. Boom. Or client has an extensive history of trauma, rape, abuse, and is seeking professional help or support. So again, presenting of the brief problem here. Referral sources and process collateral information. Be very clear here. Client was referred by a substance abuse counselor. Client was referred by their teacher, their school. Client is self-referred. Be very specific here. Be very specific so that how the handoff occurred with that client is clear. Living situation is descriptive and quality, right? If you're saying, you can say they lived in a 2-bedroom apartment, that's describing. They live with family, a mother, with family or with a significant other, lives alone, descriptive. Lives in apartment or house for 15, 20 years, descriptive. But also talk about the quality. Is it safe housing? Is it stable housing? Is it appropriate housing for whatever the client has going on? So you want to think about living situation as descriptive and quality, right? Relevant histories appropriate to the agency. I noticed here developmental students in this section just decided to use Erikson's psychosocial stages of development. Here you're looking at where the client is in their life space, their age. Are they children? Is it an adolescent? What is their chronological age? Are they older adult? And how do they fit in their developmental stage? They're 40 years old. Are they appropriately developed for a 40-year-old? And again, students oftentimes use the language of Erikson's psychosocial stage. So here you can talk about what is the psychosocial stage of development for someone who's 40 years old, for an example. What does it look like when someone has met the developmental stage? What does it look like when a client has not met it? The verses. And so now you want to talk about that here. Also, something that's key in the developmental history is if you know that there's developmental delays with that client, you can list that here. Delays in development can happen because of physical challenges, physical development, neurological, cognitive. You can have deficits or delays in cognitive. Also emotional. Those are the areas that you think about when you think about development. So physical development, emotional, psychological, cognitive, and so forth. Family relationships and dynamics, right? This is descriptive and it's quality. You need to give the reader, we need to be able to understand the client's family systems, specifically the immediate family. That's very important. So think about who is that client's immediate family: mother, father, brother, sisters, right? Sometimes students get too broad here. 4 siblings. No, we need to know, is it 2 brothers, 2 sisters? Is the client the oldest, the client the youngest? So, and then the quality of the relationship. Client has a good relationship with the mother, is estranged from father, good relationship with 2 of the brothers, distant with the sister. So again, rich description here. And think about quality of relationship. The other thing I want to encourage students to do is make sure that you talk about the right information in the right section. Developmental details should be here, family relationship here, and dynamics. That means I shouldn't see family relationship in the development, okay? And I shouldn't see development in the family relationship, right? And so it talks about how you're organizing and thinking about the material. Now, sometimes it's necessary to briefly mention or reference some things from another category in another section because it's related oftentimes. But what I don't want to see is full details that should be covered in another section. Okay. And so I do understand that many of you all have different experiences with clients, and some students may not have as much information for each client. And a lot of students don't have a lot of information in writing up case studies. So please consider my feedback as helpful to you, not just for this assignment, but also helpful for you if you ever have to write up another case study, either for work or in another class. Okay. So again, take my feedback literally for the assignment, but also take my feedback broadly in ways to help improve you in writing up case studies. History of loss and grief, right? Think broadly. Loss can be death, but loss can also be transitions in life, and loss of the life that you thought you were going to have but didn't have. Okay. So think about loss of job, think about divorces, think about rape, even, and the loss of innocence. Think broadly when you think about loss. Homelessness is definitely a sense of loss and grief, especially when you are displaced and don't have a stable home. So it's loss of safety, security, stability of a home. So think about history of loss broadly. Spirituality, right? This you need to be very clear on. Some students here mention churches, and they go to Episcopalian church, or they go to a Methodist church. Attending a church does not tell me the client's spirituality. So be very clear. Client is Catholic, client is Christian. And the church is important. Don't hear me wrong. That's a descriptor. But for me, I'm trying to understand, again, remember, these are pieces of the puzzle. So we need to present the information in the way that we can use it to fit into a puzzle. So here I'm trying to get a description of what their spirituality and religion is, but I'm also trying to use their spirituality to understand what purpose it serves in that client's life. Can I use it as a resource and a strength for that client? I need to get and understand how their belief systems are working, or how do they utilize their belief systems, because that will determine also how they're viewing their problem, how they seek help, how their family views them, how their families views their treatment and help. So again, understanding the client's belief system through the spirituality, or their attitudes about life and existence, goes a long way in helping them in understanding their problems. So again, this isn't just to tell me they're Catholic or they attend a church, or it's really showing me what spirituality means in their life, and how spirituality is influencing their presenting problems, their disorders, and again, treatment and support. Strengths, this is very hard. We oftentimes see clients as problems, and we're very good at finding problems, and we don't always spend as much due diligence of strengths. So here you provide an inventory of the strengths that you see with client. Some of the strengths are just strengths that the clients have. If we can't see it in clients, oftentimes they won't see those strengths in themselves. But we also use strengths as a functional purpose too. So what are the key strengths that can help me improve this client situation? Because we want to show in your intervention plan, mind you, where you're utilizing that client's strengths to overcome their presenting problems and issues. Resources as rich as possible. And think broadly about your resources, okay? Resources are not just our social service agency. Spirituality can be resources. Income can be a resources. People in a client's life can serve as resources for them. Education can be a resource for them. Medical doctors and providers and mental health doctors and providers are also resources. And so that's why I really encourage students to fill out as much as the contents as possible, because you may find that there are resources in areas you didn't think about. Sexual experiences here, exposures and abuse. A lot of students talk very negatively about sexual experiences. This doesn't have to be negative. This can be positive too. You can talk about healthy, positive sexual experience clients have. And I think this is even more so important if they have abuse backgrounds, sexual abuse or domestic violence abuse or sex trafficking backgrounds. One, because it may be able to show you as a therapist that even though these things have happened to them, they are still able and capable of having healthy sexual relationships, which speaks a lot about their ability to heal and move on. Domestic violence here. Just want you to really think about domestic violence in terms of, I noticed some students put child abuse there, which I conceptualize as different than domestic violence, but it's fine if that's where if you want to put it there. But make sure you list domestic violence and make sure you're detailed. Whom, when did it occur? How long did it happen? Who was the perpetrator? Who was the abusing person? Were there any injuries sustained, head traumas? Has the client been hospitalized due to this domestic violence? So again, think about rich descriptions, because these are our puzzle pieces. The more information you can put under these sections, the easier it is to put the pieces of the puzzle together. Relevant medical, psychiatric, education, and social services. Educational history as detailed as possible. If there's any delays or if clients were um, um, held back from school, that should be listed here. Educational history you can also mention here any aspiration. You may say client dropped out of college but plans to re-enroll one day to become a chemist, or also put desires there. So you want to have a good idea of where their history is, but what they want in terms of their education as influenced by their history. Okay. Um, Medical history, including medications, right? Here, you don't want to just list information. We don't want to hear you just list the diagnosis. Here, you're telling a story. This whole biopsychosocial assessment is the patient's story. It's their narrative. And so it has to be meaningful, so that as clear as you can be, the better. So don't just list diagnosis. Don't just list medications here. Talk about each diagnosis separately. Client has COPD. They were diagnosed with COPD in 2005. Client sees a specialist, a respiratory therapist. They see their primary care doctor. They see this particular doctor or provider for COPD. Client is prescribed this medication for COPD. Now, client has diabetes. Client has suffered for diabetes for 5 years. She sees an endocrinologist for her diabetes once a week, once a month, twice a year. Client is on insulin for diabetes, and so forth. So again, that section is not just listing things and throwing information under sections. It's really, what is the story? And how do I understand that story? How do I make the connections? And mind you, sometimes people are coming behind you reading your biopsychosocial assessment, so they need to be able to connect the dots and see the picture that you're creating here for the client. So again, be very clear when you write a diagnosis down, that you talk about the history, somebody that they've had it. If a diagnosis is no longer active or relevant, needs to be listed here, and align the medication, treatment, and the providers for each one. Again, not just listing them, talk about each of them separately and in a contextual way. Same thing with psychiatric history. Diagnosis, when the diagnosis was provided. Providers, is it a clinical social worker? Is it a psychiatrist? Is a psychologist involved? Are they on any medication for that diagnosis? Align the medication with the diagnosis. Okay. Under medical history and psychiatric history, you want to include any inpatient admissions and for what, outpatient treatment and for what, being specific here. Under psychiatric history, you want to include any suicide ideation, suicide attempts, suicide history, and so forth. Alcohol and substance use, again, detailed as possible. Past use and active use. How long have they been using a particular substance? What are they actively using? What have they used in the past? Right? How much of that substance that they use? Not necessarily based on client report. You can note what the client is saying, but if a client is a heavy substance user, what they think is a lot and what they think is a little is going to be different than the average person. So to get a better understanding of what their use is, you say, how many drinks have they had? How often do you smoke marijuana? How often do you use cocaine? How much money do you spend on these substances? That gives you an idea of how much they're using. How are you paying for it? Gives you an idea how bad the problem is, right? Especially when you know a client has very minimum to low income, but they're saying they're getting high every single day or using substances every day. Habits are expensive, and so where's the money coming from, or what type of behaviors are they engaged in to support the habit, right? So again, that tells you, that gives you a sense of how how significant the problem is and to what extent the client is going to be able to use substances. You also, again, want to get a sense of family history, and I'll talk more about that when we go into the genogram and EcoMap. So alcohol and substance abuse, detailed information. And these things are important because it helps us connect the dots, and it's you putting together these puzzle pieces and seeing what fits where. And again, it's the client's story. And ethically competent social worker, it's our right to paint their story as accurate as possible. When you think of socioeconomic justice, when you think of, discrimination, oppression, all those things that play a role in clients that we serve, we can't be part of that. So we need to do our due diligence and get it right for clients. We can't continue to impact them in a traumatic way by getting our diagnosis wrong, by not telling or authoring their story accurately and positively. Social services, think about all the, Medicaid, public assistance, Social Security, SSI, SSDI, and all those community resources that the client is involved in. That includes child welfare. I know we tend to think of it as punitive, but it's also social services. They offer a lot of support to clients and have a lot of services available for them. Criminal legal history, be as detailed as possible. Don't just say a client has been incarcerated 4 times. What talk about the incarcerations, how long they were incarcerated for, maybe dates of incarcerations, reasons for incarcerations as specifically as possible. Because if you know that they've been incarcerated several times for substance use and possession, that gives you an idea of how bad the substance use problem is. When you find out someone has been incarcerated and you find out they only spent 2 days, okay, that may not be that relevant or significant. But if they spent 4 years, 5 years, 6 years, if they deliver babies, for example, in prisons, okay, now we're talking about maybe trauma related to criminal history. We're also maybe talking about a form of loss, grief and loss, a loss of 2 years of their life, a significant portion of loss of contact with their family due to incarceration. I can go on and on. But also, if they've been incarcerated for 3 or 4 years and they had substance use history, then it's a possibility that they were able to go 4 years without using drugs while they were incarcerated. So again, understanding these dimensions, these categories help you piece the puzzles together, put the puzzle pieces together and make sure you're telling that client's story accurately, and hopefully you're starting to get a glimpse of maybe what the disorder may be for that client. You're also hopefully looking at the diagnosis that was provided by the agency and saying, I'm making a good case for what's already in the agency chart, or the more information I write down here, I'm starting to realize that the diagnosis that's put in the agency chart is not correct. Presentation of self. I will be sure to upload some articles to explain this concept a little bit more. Presentation of self is also includes. I'm not going to say you're wrong if you want to talk about how the client presented physically, but when we talk about the self, we're talking about the psychological self. And again, I'll upload some readings on this so students can get a better understanding of what we mean when we talk about the self in mental health, or the self in psychology. It's a psychodynamic term. We talk about the self, but more importantly, it's the client's conceptualization of themselves, how they view themselves, and it's also it's like a mirror into their mental processes and their mood, by way of thoughts and feelings of themselves. And you can use that as pieces of the puzzle to connect the other areas too. So for instance, someone who may be a sex trafficked might have a very low self-esteem, low confidence. Their measurement of their worth may be very low, right? And that may speak to mood, depressed mood, anxiousness, and so forth. So presentation of their self is their psychological representation of, or how do they see themselves psychologically. Personality, ego, functioning, defense. I didn't mention too much here for students because a lot of them did a very good job talking about that. Mental status exam is important. I'm not going to go into detail here because I have the mental status exam to show. But one thing I will point out here is that a mental status exam is a good way to describe your client outward appearance and internal processes. Mental status exams should be more detailed and more discussed, particularly if you have concerns about a client's mental stability. Think about psychotic, think about personality states, with your personality disorders, psychosis, which can be depression, anxiety, and other brief psychotic states. When you think about a client being suicidal or history of suicidal, the mental status exam is a wonderful tool. So depending on what disorder and what has happened to that client, the mental status may have a unique place in your write-up. And especially if you don't have a strong background and history on the client because you haven't seen them long enough, or you don't have a lot of information, then that means the here and now information is what you're going to be basing a lot of your diagnosis on. And the mental status exam is that here and now evaluation that you can do to gather as much information as you can, especially when the information is lacking in the history. Social roles and developmental milestones. Social roles, think about all the roles that client holds in their life. And the family piece is important with that, right? Family relations and dynamics will give you an idea what their social roles are. Are they mothers? Are they wives? Are they daughters? Are they sisters? Are they employees? What are those social roles in their life? And now you assess how they are. If it's a mother and she has all her children in placement, that may speak to her caregiving role and the status of her caregiving role. If this is a woman who used to be married and she had 5 husbands, okay, that says something about her interpersonal social roles with intimate others. So again, understanding the roles in that client's life and measuring that are additional pieces of the puzzle. Race, class, culture, ethnic group. Here you need to say more than client is a woman and an African American woman. That was captured up here. Okay. Here is not for description. This is saying, how does race, class, or another word for class is socioeconomic status, and culture and ethnic group, how do those factors, how does their race and their socioeconomic status play a role in these other areas? Does it speak to education, history, and client being left down, dropping out of school? Can race and class or culture discuss that? Speak to this? Does race, class, and culture speak to their medical history? Think about health disparities here. Think about if it's a woman of color and she has a history of low birth weight infants or miscarriages. That may have implication to medical history. Think about an African American man with diabetes and high blood pressure, right? What do we know about African Americans and health disparities. Again, that may speak here to medical history. If this is a young child who is diagnosed with ADHD and a behavior problem in school, and you're thinking that, for instance, that student might have autism and that's some of the problem rather than ADHD, how does race, class, and culture, impact that child, an African American child's experience in the educational system, their medical history, and their ability to be diagnosed properly for whatever other conditions that they have? How does being a African American child speak to their psychiatric history and misdiagnosis potentially of the ADHD when indeed that student may have autism disorder? So race, class, and culture, right? You also want to consult the literature here, understanding what it means and if there are any particular diagnoses that are more prevalent in certain racial groups. That will be the implication of race, class, culture, and ethnicity in presenting problem and disorder. Race, class, and culture also impacts how that client will engage in treatment. So you'll use this information also to think about your intervention planning. There are stigma when it comes to mental health, when it comes to certain racial groups. We definitely know socioeconomic status reduces, presents barriers for clients for seeking help and support. We know that. And so now you're again putting these pieces of the puzzle together to understand in a more broad way your client and client presenting problems and issues. Same thing here with oppression and discrimination. You may find that a client may have a history of rape, which may speak to gender-based oppression and discrimination. You may find that a client is homeless, low income, and not having and doesn't have a job. This may speak to race and institutional racism, a lack of privilege. There may be disabilities in which client became more susceptible to things that have happened to them in their life. And if that's the case, you want to talk about that here. Developmental delays also included on these disabilities. Also, you might want to think of oppression and discrimination for other groups like substance users, right? It's not uncommon for someone to be taken advantage of because of their addiction. That could be rape, that could be sex trafficked, that can be abused, and etc. So think about oppression and discrimination and how that looks in that client's life. Think of it broadly. Again, it helps put some of the pieces of the puzzle together. EcoMap genogram. Some students included a genogram in the write-up and some of them put an attachment here. I would just say, if you're going to attach ecomaps and genograms, add them all as an attachment, rather than embedding one in the write-up and then attaching the other. If you're going to do an attachment, put them both in an attachment just for consistency. But be very clear what an EcoMap is. I will upload resources so that you have a better idea of what one is and to pick one, even though many of you all did that well. Sometimes students put EcoMap and listed a genogram or listed a genogram and put an EcoMap, and they're different. The summary that you wrote up in the sections is supposed to be the summary of the actual visual diagram that you put up. Some students wrote a narrative about an EcoMap or a narrative about a genogram and never attached one. So if you didn't attach a genogram or an EcoMap, then there is no write-up, because your interpretation or your write-up is your summary of the actual diagram that you created. Brief diagnostic summary, your DSM-5 and person and environment. The person and environment, the EcoMap and the genogram can help you have the discussion of person and environment. The DSM-5, okay, the DSM-5, you need to, every case study guide should have had one of these. Couple students did not put it in or did not make it clear. It should be very clear what the DSM-5 diagnosis is, not the agency's disorder, what you think it is based on you putting the pieces of the puzzle together here. Many students just regurgitated the chart, that the disorder that was placed on the chart, which is okay if all these areas indicated that the agency-based diagnosis was correct, which I find is often not the case. What I'm asking students to do here is to take all these pieces of the puzzles and start connecting the dots to create your picture. Once you get here, even though all the information can't always be answered, right? Think about a jigsaw puzzle. Sometimes you don't need all the pieces to put together to make out what the picture actually is. And here, this is you creating the picture, your DSM-5. Now, after I put all these things together, this is my disorder. One of the things that make the order defensible and justifiable is your ability to connect these dots as much as possible and tell this story in an eloquent way that leads up to this picture, is what you're doing here. Try to do this with one disorder. I strongly discourage client students from using two. Why? Because it's hard enough getting one diagnosis right. Two, you want to be ethically responsible and do our due diligence and not just add diagnosis because it's easier for our conceptualization. That's not fair, and it's a social justice issue with our clients. So here, your DSM-5 diagnosis should be putting these pieces of the puzzle together and coming up with this. So your disorder should be able to capture as much of these puzzle pieces and connect as many of these puzzle pieces. Now, is it possible that your disorder may not capture every single piece? Yeah, that's possible, and that's okay. But what makes your diagnosis strong is making the case that most of these puzzle pieces are met. When you come up with your DSM-5 diagnosis and then you write out the full criteria for it, now you're going backwards. This is how your checks and balances. This is your double checking with your calculator. Now you're going back and looking at each of the symptoms and trying to make a justification or discuss in narrative form how these dots are connected to either specifically align with the symptoms or how these problems manifest into symptoms in the DSM-5. Okay. So again, you're now trying to translate the presenting problems, and you're trying to either find direct symptoms within these sections, or you're trying to demonstrate or make the case or tell the story of why these problems or these things, the problems and the information, data, screen, evidence, all this information here, how it's fitting in your DSM-5 diagnosis. Pulling your hair out yet? That's a good thing. Not that because I want you to be bald, but it really speaks to the work. If it's getting frustrating, if it's getting challenging, that means you're doing the work of a clinical diagnostic social worker. If it's too easy, you're probably not doing the work right. And so I want to really encourage students to really think about the work involved and take their time and get it right. It's why I told students, once you write up your case study guide, do it early, then go back and revisit this, because now you're playing with the puzzle pieces. You're trying to make the connections and align it, and you have to be very comfortable with the information that you put in here and make sure it's comprehensive enough. And I talked to some students about some of these areas not being filled out or not. What I was saying to you is you don't have enough puzzle pieces. How are you going to put this puzzle together without enough pieces to put it together? And so now you get to your DSM-5. Here for the intervention planning and goals of intervention, think goals as in broad. This is where we're trying to go. So the state I'm trying to get to is Maryland. Your objectives are the interstates, right? The roads that you're taking to get to the state, right? So for your goals and intervention for your client, the goals are the broad overarching, this is where I'm trying to go with this client. And the objectives for your goals are, these are the steps that I'm taking to get the client to meet the goals that I stated for the client. Goals are broad, tasks and objectives are more specific. Okay. One of the things that I want to see here is that the goals and the objectives are aligned with all the presenting problems and the disorder, symptoms and disorder. Okay. So go back when you go write your goals of interventions, when you're thinking about your intervention plan, you want to make sure that you are focusing in areas that help improve their experiences with their disorder, relieve symptoms, address whatever the nature is of their disorder. But you also want to make sure their goals include any areas of challenges you notice with family, history of loss, resources, violence. If you identify presenting problems with education, if you identify medical history and you saw that that client didn't have any providers or had a lot of hospitalizations, right? A lot of STDs, that should find its way into your treatment plan. If you mention that client had substance abuse, intervention plan should address substance use, and maybe that's using some of the social services. So sometimes the intervention plan doesn't mean you're doing it. Maybe it's connecting them to social services. Maybe you're improving strengths. Maybe you're strengthening that client's spirituality to cope. Maybe you're improving client resources. Again, you're fitting the puzzle pieces. All of them fit together. So your goals of intervention may be to help improve the presenting problem as well as the DSM-5 disorder. So for every problem you listed in that case study, I need to see an intervention plan for it. Again, this will require you to do your due diligence and not just put the intervention plan that was put in by your agency, because your agency is limited. Oftentimes, your agency is only focusing on a particular point. So if you have a mental health agency, and the mental health agency may help you come up with or help you think about what are some of the interventions you will put for the DSM-5 diagnosis. The mental health agency is not going to necessarily work on education. But if you listed education as a problem, you have to write an intervention for it. That's why we're moving away from what the charts are saying and what your agency is listing as the diagnosis. That's why we're moving away from what the agency put as the intervention plan. You are the social worker for this client. So what is your intervention plan? And so again, medical history, if you put medical conditions, I want to see an intervention addressing and focusing on how you're going to improve that client's medical status. Psychiatric history, how we're going to improve their psychiatric. If it's substance use, how we're going to improve substance use. If they're involved with social services such as CPS, how are you going to help this client resolve their issues with child welfare? I want to see that in your intervention plan. Termination and follow-up, again, make sure that it's aligned with what you put in your presenting problems. Ethics and ethical dilemmas, I talked about it through this video, our professional use of self. How do we use ourselves to improve clients? What are the values, maybe social work values, that you're going to apply when working with this client? And what are some ethical considerations? Think about misdiagnosing. Think about adding think about someone who already has 3 diagnoses. Do we really need to add a new one? That's an ethics. That speaks to ethics and ethical dilemmas. I really caution students from adding a new diagnosis, particularly when clients already have one, just because it makes it easier for you to diagnose. No. Sometimes it's in the best interest of the client and best professional practice to see if maybe one of the ones already provided is more accurate given the information you put in the other pieces from the other pieces of the puzzle. How would you evaluate your work? How do you know the goals have been met? How would you know the client is indeed progressing? That's what this is asking you to think about here. Avenues for leadership and policies. This is from a macro perspective related to the disorder or things that went on in the client's life. What are some of the housing policies you would try to change to avoid clients being homeless? What are some of the policies you would put in place to help people not experience trauma and violence that lead to PTSD, for example? What type of programs and service would you put in place to help support substance using people? And what does promotion of social justice here? Think about all the social justice implications for race and culture and oppression and discrimination, and think about what that would look like with your client. For time's sake, I also want to take the time to talk about the mental status exam really quickly. This is a tool that we use. It's an additional assessment, right? But it really helps you understand what's going on with your client, okay? It helps you describe your client in an objective way instead of saying, oh, client is depressed or client is anxious, right? Which seems very opinionated. Now you can really objectively observe and talk about your observations. This is also important if you do not have a good, strong history for your client. If you don't have a strong history, you only have the here and now. You only have the contact, that one or two contact you have with client. And so this will help you maybe create some puzzle pieces to put together here. So this is important also when you're thinking about client who have worsening symptoms of depression or anxiety. If you think a client, for instance, is hoarding, this has special implication and a special purpose depending on what disorder you're thinking about for your client. So when you're thinking about clients and whether they have personality disorders, if you're thinking that they might be psychotic, right? You want to think about describing what they look like and their outward as well as their internal presentation, appearance, behavior, attitude toward the interview, affect and mood, speech and thought, perceptual disturbances, right? This helps you know if somebody is psychotic as well and whether they have any personality disturbances. Orientation and consciousness, memory and intelligence, reliability, judgment, and insight. These things are important. This is language of appearance, general appearance, physical characteristics. Did you see cuts in their arms? What did you see? Were their hair cut? Was it long? Were their nails dirty? What did you see here? Grooming, facial expressions, perspiration, use of makeup. All these things help you understand whether this client may be going through a psychotic episode here. Or if their condition of whatever your disorder you think they may be suffering from is they're worsening. You're using this assessment tool to see how well that client is at any given time. And then it gives you more explanation here. These are some of the things you can use to talk about clients' attitude. And please use this. Affect and mood, which is good for trying to make a case for depression. For diagnosis that really requires some behavioral language to provide evidence. You can use these type of behavior description to try to get to the bottom, again, piece the puzzle together to what the disorder may be for this client. Speech and thought, which may speak to personality or psychosis or concerns with your client, and so forth. This is a very helpful, useful tool, particularly related to the disorder that you think that the client may be experiencing. This can be a valuable tool and way to justify what you see. Again, this is a tool that you always also use if you don't have that background information on client. One more thing I'm going to speak to for students before I move on is the importance of writing out that full criteria. When you're thinking about somebody in a psychotic state, that may not be oriented, that may not have recall to where they are, what they're doing, psychotic or personality states, right? Whether it be a disorder related psychosis or a worsening symptom or worsening disorder that's turning to psychosis. Please be mindful that a client's substance using history is key here. It's very hard to make a claim that somebody's having a personality disturbance or a psychotic episode if they have a significant history of substance use, and particularly if they're actively using. Many of the disorders are ruled out due to substance use. That can be illegal substance use, such as alcohol, marijuana, cocaine, PCP, things like that. But also it can mean medication prescribed by a doctor can make someone appear as though they're having a psychosis or a disturbance in their personality. Prescription illegal and legal drugs can also alter mood states. So when you're thinking about depression or anxiety, racing thoughts, when you think about manic or hypomanic, substance use individuals will appear that way. And so using substances can mimic a lot of your mental health disorders. So you have to now call into question whether it's substance use causing this or the exact disorder. It's why oftentimes substance use will rule out those disorders, because oftentimes we can't always be sure it's not substance use causing these symptoms. So please be mindful of that, when you're writing up your case study. The other thing is, for many of you, I also mentioned that they didn't have enough medical history. This has this has direct correlation for psychosis, and personality disturbances, right? And sometimes mood too. Again, there are some medical conditions, such as diabetes, that tends to be a hormone imbalance that can cause clients to be depressed. We want to make sure they actually have depression and they don't have diabetes that's causing them to be depressed, which is different. It's not that you don't treat them for depression or a depressed mood, but your intervention plan will be different if it's related to diabetes. Because if you manage their diabetes better or find another medication to manage the diabetes, um, their depressed mood will improve. So again, there's for some of you, for some students, I really talked about lack of medical history. You have to be mindful that that medical history, whether this their diagnosis and conditions, that's why putting that history and that detailed information is important. That medical history, whether it's the diagnosis or the treatment for the diagnosis, can mimic mood disorders, um, and overall DSM-5 disorders. So again, please be very, very, very mindful that you got to put these pieces of the puzzle together and make sure that you're not ruling out or negating your diagnosis because of information that you put already down in the case study guide. I hope this was helpful for you. Thanks.